listening to the Pharmacy Podcast Network.
Pharmacy benefit managers, better known as PBMs, are responsible for negotiating payment rates for a large share of prescription drugs distributed in the United States. Recently, state Medicaid systems, policymakers, and national pharmacy associations have expressed concern that certain PBMs' business practices may not be consistent with public policy goals to improve the value of pharmaceutical spending. This podcast series is all about PBM reform. Listen to the discussions, share these podcasts, and help build a new pharmacy payer system which supports our independent community pharmacies, encourages fair and transparent competition in the marketplace, and most importantly, is designed to deliver the best patient care.
Welcome to the PBM Reform Podcast here on the Pharmacy Podcast Network. I'm your host, Breck Rice, and I have had the privilege of being around and working with pharmacies for over 20 years now, and it's really been my privilege and pleasure. I'm not a pharmacist myself, but I love community pharmacy, and I'll do everything in my power to help them be successful. Have an exciting show for you today, and let's get into the podcast. Welcome to the Pharmacy Podcast Network. My name is Breck Rice. I'm your host, and this is the PBM Reform Podcast. And I'm super excited today because we have Congressman Buddy Carter. You all know him and love him. You've seen him at our conferences, and he might be your neighbor too. So we're very excited to have Congressman Carter here to talk to us today about PBM reform. And he has obviously been very involved in that in the House, and besides all of his other duties that he has. But we're super excited to have you here today, Congressman. And how's your morning going?
It's good. It's great. Thank you for having me.
Yeah, I appreciate you taking some time out of your busy schedule. A lot going on right now. And there's so many things rabbit holes we could go down on that's happening right now with you and your life in the Congress. But we want to focus more on, what can be done and what should be done about pharmacy benefit managers and reforming those programs today. But I got to ask you, because everyone knows that you're a pharmacist, and you obviously have the best interests of our community pharmacists at heart. So what was that driving factor that said, I need to get into politics?
Well, I get asked that question quite often, and look, I've lived a blessed life. My dad. He worked in a paper mill, worked shift work. He worked hard, and he provided for our family. I was the first one in my family to go to college and to graduate, and came back home and was able to work for someone for a while and then build my own business. So I just feel like I've lived the American dream, and I just want to give back to the community that's given so much to me, to the state, to the country that's given so much to me. So it's just I didn't have the honor of serving in our military, but my honor is to serve those who have served and who do serve. And this is just my way of public service, and it's very important to me.
That's amazing. And how many years has it been now?
Well, I actually started, I was on city council, and then served on city council for 2 years, served as mayor for 8 years, and the Georgia State Legislature for 10 years. And now this is my 10th year in Congress. So I guess that's what, 26 or so years. I tell people I started when I was 10, so that explains that.
Yeah, of course. Back when you first started, you were also double duty. You were running the pharmacy as well.
Yes.
As serving.
That's right. I'm no longer on the pharmacies, but I still have my license. I'm certainly not going to give that up for this gig, but nevertheless, I worked too hard for that license, as all of us did, and I'm very proud of it. Very proud of our profession. And I just don't think I could have chosen a better profession than pharmacy. I mean, I was very fortunate when I was in high school. I wanted to be a star athlete. Unfortunately, not only was I short, I was also slow, so it just didn't work out. But nevertheless, I got a job in a pharmacy, and it was just, it was just God's calling for me, because it was perfect. It was healthcare, helping people. I'm obviously very extroverted, so interacting with people, that was very important to me as well. So I just, again, I don't think I could have chosen a better profession than pharmacy. It's just been a blessing for me.
Yeah, it really is not just a blessing for you, but obviously the community that you serve. And all of our independently owned pharmacists are serving specific communities around the country. Such a vital need. And it's so sad every time I see that one has had to close its doors.
Thank you for mentioning that, because that is extremely important. And that's a point that I'm always making up here in Congress. And, look, whether you're a Republican, a Democrat, or independent, we all want the same thing. We want accessible, affordable, quality health care. Pharmacists are the most accessible healthcare professionals in America. 95% of all Americans live within 5 miles of a pharmacy. We've got to continue to have retail pharmacies. Otherwise, accessibility to healthcare is going to decrease in this country. That's why I'm so proud of our profession and the way that we stepped up to the plate during the pandemic. Because pharmacists not only provided counseling, vaccinations, medications, every testing, everything we did, and it made me very proud of our profession. And it also, I think, drove home a point up here in Washington, D.C., and that is just how important our profession is to the healthcare community.
Absolutely, absolutely. My day job is with a company that helps pharmacies get fair reimbursements, and I partner with our pharmacy service organizations, the PSAOs, and so I constantly get updates from them about who's joined their network or who's going to a different network. But the saddest thing, the update that I get is closures. And we just had another closure on Valentine's Day just, yesterday. So it's really sad to see our independents close, because it's not just sad for that independent pharmacy owner, but now that community that they serve is going to most likely have a pharmacy desert now. Yeah, have you seen that happen?
Right. Mm-hmm. Yeah, we have seen it happen, as you know. And if I could just interject this as well. When I became a member of Congress 10 years ago, the first thing I did was to go to the FTC, the Federal Trade Commission, and ask them to look at the vertical integration that exists within the drug pricing chain, where the insurance company owns the PBM, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. And finally, after I guess it was about a year and a half ago, they finally undertook a study. It's called a 6B study that the FTC is looking at now, of the impact of PBMs on independent retail pharmacies. We know that independent retail pharmacies are closing at like 4% a year. And that's just got to stop. Otherwise, we're going to impact the accessibility to healthcare that I spoke about earlier. But already, the study that was undertaken by the FTC, and we get updates about every quarter or whatever, but they told us, look, it's probably going to take 2 to 5 years to finish this study. But as we go through the process, we are going to address egregious practices as we come across them. Already, the FTC has retracted statements that were made early on about the benefits of PBM, and they've gone back and said they no longer are benefiting patients. I think that's significant. I think I really do think that we've made progress, particularly within the agencies and within Congress, of bringing to light just the problem with the middleman and the problem with the PBMs and drug pricing.
Yeah, that is huge. That is so huge. I was listening in on the first hearing that the FTC had a committee set up, and it kind of sounded like a couple of those board members, or the people that had been chosen for that committee, had the PBM playbook. There were over 200 pharmacists that were there on that call to give their testimony about how they're affected personally. No one spoke from the PBM side, because I think somebody on that committee had the playbook. So I'm glad that got reopened, and that the chairman was, saw that things really hadn't gone the way that they probably should have, and reopened that up so that we could get to where we're at now today. So exciting. U.S. News and World Report, they've reported that prescription drug costs are the fastest growing cost to the healthcare system today. And so when you look at that, you said where the integration is happening, and now the PBM and the health plan are the same company. You see that drug costs are going up, but yet pharmacies are making less. Why is that?
Well, there was a study done, and it's a little aged now, but it's still relevant. It was a study done by the Berkeley Research Group. And what they showed was that only 37% of the price of a drug goes to the pharmaceutical manufacturer, which begs the question, where does the other 63% go? It's going to the middleman. It's going to the insurance company, the PBM. They're the same thing. The PBM owns, or in some cases, the insurance company, and in other cases, the insurance company owns the PBM. But they're all the same company. And that shows you, just that study shows you what the problem is right there. And pharmaceutical manufacturers need to do a better job. There's no question about that in their pricing. We all agree with that. But at the same time, the real problem is in the system itself, the PBMs and the middleman. That's where the cost of the medication is. And I would be okay with that if that were, those savings were being passed on to the patient. But they're not. They are being used for profits. That's why we've had legislation in the Georgia State Legislature. I was down there about a month ago speaking on a bill that they had before the Health and Human Services Committee that would have required 50% of all of the discounts that PBMs get to go directly to the patient at point of sale. Unfortunately, that bill didn't pass, but that's the kind of initiatives that we need, particularly on the state level. We've made great strides on the state level and combating some of these PBMs and combating some of their egregious practices like spread pricing and like the DIR fees, all those things that are just crushing independent retail pharmacies.
Yeah, absolutely. I haven't been around pharmacy quite as long as you, Representative Carter, but for over 20 years. And back when I first started, the margin for dispensing a medication was about 36% for the pharmacy. That's a fair margin, and patients were paying less. Now today, that margin is as low as 3 to 5%, and the patient is paying more. And so, you've explained it beautifully of why that is, and it comes out of that spread in the middle. I suspect, when I look at what the true reimbursement for a third party payer is for certain medications like meloxicam, if that were billed out, at the state fee schedules of the different states of jurisdiction, pharmacy should be making about a $90 to $100 reimbursement for that medication for a 30-day supply. But you look at their PBM reimbursements, and it's $4 and $5 is all. So where did that $95 go? Well, it went into the pocket of the PBM, which is really unfortunate.
It is unfortunate. And they will argue, well, we're keeping premiums low. We're using this money and it helps keep premiums low. But I don't know about you, but my premium had gone down and it's not low. So there's really a problem. And I always am quick to point out, I'm not opposed to anybody making money. I get it. We live in a capitalistic society and I understand that. But this is more than just making money. This is, it's funny, the Attorney General of the state of Ohio referred to the PBMs as gangsters for the practices that they are doing. Now, that's what he said, not me. And it's true. They are modern day gangsters.
Yeah, yeah. I've been quoted of saying that a couple of times too, so I'll take some responsibility for that. But yeah, it is but I've had personal experience there, right, where I had to be quiet for a couple of years and not tell my pharmacy partners that they were getting taken advantage of. So, Representative Carter, what would be some proposals that you have to help with PBM accountability?
Well, that's a great question, and I appreciate the opportunity to share with you because I serve on the Energy and Commerce Committee, and the Energy and Commerce Committee is where the Health Subcommittee is. So obviously, I'm where I need to be and where I want to be. And we've passed a bill out of the Energy and Commerce Committee, out of the Health Subcommittee, and then an Energy and Commerce Committee, and out of the House. It's over in the Senate now. It's called the Lower Cost, More Transparency Act. And it's got two of my bills in it. It's a conglomeration, if you will, of different bills, all of them having to do with trying to lower costs of medications and increasing transparency. That's the key here, is the transparency part. And two of the bills that I have in there, one of them is the Drug Transparency and Medicaid Act. And what this does is it just ends spread pricing in the Medicaid system. And we all know what spread pricing is when the insurance company pays $5 for a drug but charges $10 for it. That's what they refer to as we all know, spread pricing. This would eliminate it and prohibit it to be used in Medicaid. We want to expand that to Medicare at some point, but this is the best we could do at this point. So we're going to start with Medicaid. That's one thing that it does. The other thing is that the other bill that I have is the PBM Accountability Act. And what that does, and this is the transparency part, is it lets the employers see what the discounts are that the PBM is getting, not the patient, but the employers. These employers need to understand that they're getting ripped off. And, their patients are getting ripped off, but they are getting ripped off as well. That's where this transparency will come in handy so that they can see the discounts that the PBM is getting. They can see where they're going, and they know they're not going to the patient. This increasing transparency like this would certainly help. Both of those bills are within the Lower Cost, More Transparency Act that has passed the House and is now in the Senate. We need to get it passed in the Senate. The Senate's working on some bills as well. Bernie Sanders, of all people. I mean, when you get me and Bernie Sanders and AOC on the same page, and that is in trying to bring down drug costs, you've achieved something. I mean, we've got conservatives and liberals all working together because I'll tell you, in my years of practice in pharmacy, I never went to the counter and said, are you a Republican or a Democrat? That's how much is the price? That's going to determine. It doesn't determine. It doesn't matter. It's all the same. It's about patient care and about the patient's ability to get those medications. So it really is the Senate's got some legislation. We're looking at it carefully. We're concerned about some of it because we don't want it to be preemptive. In other words, we don't want the federal laws to preempt the great success we've made on the state level. We've got some states that have really done great work in reining in the PBMs, and we don't want that to go by the wayside because of federal preemption. So that's the very important part there. We don't want to do more harm than we do good. We do want to try to do something at the federal level, but let's not undo what the states have done because they've made a lot of good progress.
That excellent point. Excellent point. When you started naming off some of the folks that you work with, that could be a good start to a joke, right? Sanders, Carter, and in a room together. Yeah, it could be the start of a good joke. But when you talk about at the state level that good things are happening, I'm super proud of my home state here in Arizona because we were one of the very first. Not that long ago, too. I mean, you look at it, it was just 3 or 4 years ago when we still had gag clauses inside of those PBM contracts. So the poor pharmacist couldn't even tell the patient, your cash price would actually be cheaper than your copay for insurance. So super proud of our state being an early adopter, and then more proud that a bipartisan bill was passed to make that a national law to take those gag clauses out of contracts. What do you think about the bundling of contracts? Because there's some really good studies that show that it truly does cost more to process one specific claim, like your claims where the patient hasn't pre-enrolled. So in Medicare, Medicaid, in your health plans, patients enroll in those during the enrollment period. So eligibility starts because you know that that patient is with that particular plan. But your entitlement programs like personal injury, auto, or workers' compensation, those patients don't get enrolled until after the injury occurs, right? So there's 2 or 3 days there before it's even set up, and there's an ID and everything for the pharmacy. So that obviously costs more in time, effort, energy, making phone calls to check eligibility. But yet the PBMs have wisely bundled that all into their managed care contracts so they can pay the very lowest point of reimbursement. Do you think there's an opportunity there to unbundle those networks so pharmacies can really choose which networks that they want to participate in?
That's our hope, and that's our intention, and where our efforts are focused is to bust this up. Is to another bill that I've got is the Protecting Patients Against PBM Abuses Act, and this would delink the price of the drug from the compensation from the PBM, which would help. But there's another one called the No PBMs Act, and this is another bill that I've got. It's still in committee, not passed out yet, but still in committee. But this would give the pharmacies the option, if they so choose, to enter into a contract with the PBM. So often right now, PBMs are shutting them out, won't even let them be in the contract. But if they're a willing provider, they can get in, and that's what this bill will do. But you're right, we've got to bust up this bundling, because listen, you got to give the PBM their dues. They're big. These are big. These are some of the biggest corporations in America. And in fact, I want to get this in because I think it's kind of an astounding point. The largest employer of doctors in America right now is United Healthcare. Employ over 9,000 doctors. And that's where I hope the FTC is going to step in and bust this up and say, look, no pharmacy should be owned by a PBM. No insurance company should own a PBM. We need to bust up this vertical integration. That's where the problem is in my mind. But listen, again, you got to give the PBMs their due. They're smart. They know what they're doing. And I refer to this sometimes as like squeezing a balloon, because if we can solve one of the problems, then they just make up for it somewhere else. I mean, we take away the DIR fees. They already know what they're going to do to make up for it somewhere else.
Yeah, exactly. Yeah, we saw legislation, come up in my home state here over and over and over again for the PBMs trying to control more of the channel of distribution of medication, because if something was bypassing them, if a doctor had a small little dispensing pharmacy in his office to take care of, some patients that may just not feel like going and waiting for a couple hours to pick up their medication at the pharmacy, they could dispense it right there at their office. Well, that was bypassing the PBMs. And so we saw year after year lobbyists coming in to try to fix that leak for them, because they wanted to control it. They wanted it all in their network to get their cut, their spread that was in there. Well, Congressman, what can be done about the clawbacks? Because that's what everybody's so concerned about. And it's so hard to even identify what that amount is going to be. We've seen that increase go up by, what is it, 9,000% or something ridiculous like that? What can be done about those?
Yeah. We thought we had those taken care of at one point. Unfortunately, it was like at the last last minute the rug got pulled out from underneath us. But these are probably some of the most egregious practices of the PBMs, because, as you say, in many cases, you don't know how much it's going to be. And, they've made them real time now. I think, in fact, the first quarter of this year, I think they made them to where they had to do them real time, which really caused a lot of problems for pharmacies. And I hope that, and that's why I think you're going to see an uptick in the closure of some of the pharmacies during this first quarter, because not only are you making up for a previous quarter, but now they're in real time. And so you got a double whammy right there. But we did have time to prepare for it. And my hope is that most pharmacies did prepare for that. But again, those are some of the most egregious fees that the PBMs have. And we really do think that we can get rid of those. But I just caution you that when we do, they're going to do something else. I mean, they're not going to let their revenues go down. Listen, they're traded on the New York Stock Exchange. Revenues go down, their stock price goes down. So they're not going to let that happen.
Yeah. Now, and for our listeners that aren't intimately involved in pharmacy, let's put some of those DIR fees, the direct indirect remuneration fee, in perspective for them. Everyone complains, from time to time about gas prices. Well, that inflation on DIR fees would be the equivalent of having to pay $3,700 per gallon of gas. So
Exactly.
Gives you some idea from what the pharmacies are having to deal with in having to pay out those clawbacks. Mm-hmm. Yeah, very, very sad time. So, well, Representative Carter, I sure appreciate your time. Is there anything else that absolutely the public needs to know, or your fellow pharmacists need to know?
Well, one thing I just want to encourage my fellow pharmacists, we need your advocacy. We need you to get in touch with your representative, with your senator, and let them know. And patients, listen, there is nothing more powerful than patient testimony. We've got a pamphlet that we put together, Pulling Back the Curtains is the name of it, that is essentially patient testimony about the impact that PBMs, the negative impact that PBMs have had on people trying to get medications. The cost of the medications, prior approvals where they couldn't get their medications, and the negative impact, as I say, that has had on their health care. But that's what we need. We need grassroots advocacy. We're a citizen legislature. We have 2 pharmacists in Congress now. We have lawyers. We have new car salesmen. We've got way too many lawyers. But at the same time, that means that we need to educate members of Congress. And that's where citizens, patients, and pharmacists can come in and help us.
Very well said. Thank you so much again for your time. It's been a pleasure visiting with you, Representative Buddy Carter. Thank you.
Thank you.
Thank you for tuning in for Critical Conversations to Drive Meaningful Change here on the Pharmacy Podcast Network, PBM Reform Podcast. From the front lines of community pharmacy to your ears. Please remember, when change is needed, it's everyone's responsibility to speak up. Until next time, be well, be kind, be involved.
PBM reform is not a textbook process. This component of healthcare insurance will take time to figure out and will consist of many different players of the pharmaceutical supply chain. If you'd like to contribute information, data, or your own insights on PBM reform, please contact the Pharmacy Podcast Network. Send your email to publisher@pharmacypodcast.com or call us at 412-585-4001.